Great. Thanks so much, David. And it's been a terrific conference, and we've had so much fun learning from everybody. To answer David's question, there is a a consensus document that's going to be coming out from the Society of Thoracic Surgeons on some of these guideline recommendations for surgical decision making. And today we're going to talk about just give an overview about surgical considerations. In 2025, surgical approach is very important. And so we really need to be focusing on minimally invasive operations. What does that mean? So traditionally, the way to do lung surgery is, and when I was a medical student, I saw a lot of these. You go from front to the back, a big incision, and then you have a controlled break of the rib, and then you spread the ribs open with this. Let me see if I can get, yeah, this retractor called a finichetto. It's a safe way to do an operation, but especially with screen detected lung cancers that are really small, it's much better to do something else. And there are two approaches I'll just briefly talk about. One is called VATS. So this is video assisted thoracoscopic surgery, where you have small incisions and long, thin instruments. In this diagram, there's two instruments there, and then the camera is going through here. But there's different iterations of this, including two incisions and one incision. And then the robotic approach, which is essentially these arms that you see right here, they hold the camera and these long, thin instruments that you see in the VATS operation, but the surgeon is sitting at the console and maneuvering these robotic arms. And then this is a picture of what it would look like in the operating room, the robot with the small instruments there. People with minimally invasive surgery, they do really well. This is one of my patients. I did a uniportal wedge resection, and she had one incision right there. And text messages she sent me, which was, she said, quick update from 1 week post-surgery. I'm currently on the train to Washington, no problem at all. Except, of course, having help with my luggage. I've been walking between 6,000 and 9,000 steps a day. I can breathe in deeply pretty deeply, including a yawn, but only some aching. Coughing still hurts quite a bit, but all pain is being managed only with Tylenol and a few pills of Advil. No narcotics, no breathlessness, no shortness of breath. So overall, folks do very well with minimally invasive surgery. What did surgery look like in Nelson and NLST? This is something that I thought about. And one question is, how many thoracotomies did patients get in these trials? So to just take a moment to guess in your mind what the percentages are. When I thought about Nelson, this was published in 2020. And so I think of Nelson as a contemporary cohort. And this probably will surprise you. So NLST, 70% of thoracotomies, 70% of resections in NLST were thoracotomies. And in Nelson, it was 94%. And if you look at the accrual, 2002, 2004, 2004, 2008, this is a time when minimally invasive surgery was still developing and not quite in the mainstream yet. But nowadays, 80% of resections for stage 1 lung cancer are performed minimally invasively. You see the thoracotomy line going down, VATS and robotic lines going up. And in 2025, it's probably even higher than that. So surgical considerations, approach is important, minimally invasive surgery is important. And going back to this question of what is minimally invasive surgery, I thought it was important to pay homage to where we are. And Dr. Raja Flores was a real leader in pioneering minimally invasive techniques. I remember this paper coming out and seeing this presentation in 2011 in JTCVS in AATS, where at that time, there had been single center trials talking about the safety and feasibility of thoracic surgery with minimally invasive techniques, but nobody really talked about the catastrophic intraoperative complications that were rare, but that could happen. And it was really brave and courageous paper that when this happened. And if you look at the year, this was in 2011. So this was when NLST was published. So it gives you a sense of where minimally invasive surgery was at the time, and then also where we are now in 2025, which I'll show you some outcomes, and everything is really safe. Now, yesterday night, I learned also that Dr. Flores is also actor Raja Flores. So do you all know that right now, Dr. Flores is in movie theaters right now, AMC theaters. He is in The Smashing Machine in 2025. Now, I only learned of this basically at 9 p.m. last night. So we're just trying to figure out how do we get footage of this. But our team was terrific. And with the same urgency that they do in teaching people about lung cancer screening, we actually were able to find a clip. So let's see if this works.
Hey, Mark.
Hey, Raja. How's it going? All right, man.
Great. You must be a little jet lagged.
Yeah, just flew in this morning.
Where'd you come from again?
Japan.
So UFC's now in Japan?
No, it's kind of like an NBA, ABA situation. Two different leagues. This one's called Pride.
Well, why don't you take off your shirt? Let me take a look.
Great. So this is out in theaters. So I I could spend the rest of this talk talking about Dr. Flores, but he's a true Renaissance man. In the interest of time, I do have to talk about lesser resection as good as lobectomy. And so this is just a couple schematics. Wedge resection is when you take a little bit of lung out, and it can be quite small, just a tiny bit of lung out. And then the traditional operation, was a lobectomy, where you remove the entire lobe, which, as you can see, even with this just rough diagram, a lobe is a lot more lung than taking out a wedge. The right lung has 3 lobes, the left lung has 2 lobes, and a lobectomy was the traditional operation for these kinds of small tumors ever since probably 1995 until 2023. And this is perfect. Dr. Al-Torki is walking in. So Dr. Al-Torki, so you can see in New York, the New York surgeons have done a lot for thoracic surgery. Dr. Al-Torki published this landmark trial, CALGB 140503, in the New England Journal, showing that either you can take you can take more lung in the form of a lobectomy, or you can take less lung in the form of a wedge or a segmentectomy. And the outcomes are very similar. There's no difference in disease-free survival. So I would argue that for screen-detected lung cancers, your surgical consideration, especially if it's in the periphery, should be prioritizing sublobar resection. We need to be aiming for a very low complication rate. So these are outcomes of screen-detected lung cancer from the National Lung Screening Trial. Our team took a look at this, and the 30-day mortality for stage 1A was 1.3%, and 90-day mortality was 2.4%. So this is probably way too high. In Nelson, it was 0%. They don't have the 90-day mortality. In more modern day cohorts, the 30-day and 90-day mortality is 0%, and it should be as close to 0% as possible. So the Baptist experience, Massachusetts General Hospital, Mount Sinai, Leahy, everything was 0%. 0% for 30-day mortality, 0% for 90-day mortality. Cincinnati was 1.2%, so it was 1 out of 82, but it was 1 patient out of 82. So I think in this day and age, a lung cancer screening program, screen-detected lung cancer surgeries the expectation should be as close to 0%, and it is for many centers. And then the 5-year overall survival rate is also much better when compared to the NLST. NLST is 70%, and then in all these cohorts, it's around 95%. Last thing we'll just mention is we need to be aiming for a very low benign resection rate, as we had talked about. I think it's worth talking about again, though, because people often, the naysayers for lung cancer screening, they always like to talk about benign resection rate, and they like to throw out these numbers of 24% to 28%, NLST Nelson. I remember a talk given to 7,000, mostly medical oncologists and pulmonologists, and it was just right there, 25% benign resection rate. It's not that high anymore. So as we had mentioned, Balata et al., 5 UK-based lung cancer screening programs, it was as low as 4.6%, and then Manchester Lung Health Pilot, 2.5%. These other cohorts, some of them are 10 to 15%, but I just wanted to highlight when are these studies done? It is still relatively old data. So 2015 to 2019, 2014 to 2021. In 2025, especially with the use of better biopsy techniques with robotic navigational bronchoscopy, with better imaging and with better guidelines, the benign resection rate really needs to be much lower. And probably is. The reports just haven't been published yet. Another important number, though, I think, is the proportion of low-dose CT scans which resulted in a benign resection. Oftentimes, people get that confused. And really, I think the proportion of low-dose CT scans which result in a benign resection, that's probably even more important. And even with the NLST, where the benign resection rate was 28%, the number of patients who were getting benign resections as a result of CT scans was still really low. It was 0.11%. So in summary, surgical considerations for 2025, got to go for a minimally invasive approach. Sublumbar resection as good as lobectomy for tumors less than 2 centimeters. We didn't talk about this, but really it needs to have appropriate staging from surgery with lymph nodes, and then you can expect faster recovery, extremely safe outcomes nowadays, about 0%, 30 and 90-day mortality, low benign resection rate, and the proportion of low-dose CT scans resulting in benign resection rate as low as 0.07%, and excellent quality of life with minimally invasive operations. And then just end on one slide. This is really what minimally invasive surgery should be all about. This is one of my patients, Mr. Bromley, who had his lung cancer found early 5 years ago. He actually had small cell lung cancer detected early and did a robotic right upper lobectomy for him. And then 5 years later, he's still doing really well. On his 80th birthday, he drove 90 minutes to come over to teach a whole bunch of students and inspire them about lung cancer screening, early detection, and advocacy. Thank you.